So what then can we do about it, and what type of policy and advocacy has been done? Well, honestly, way back in 1980, the World Health Assembly convened in Mexico City, and there was a very forward-thinking Director General of the World Health Organization back then, and he actually said surgery and health for all. So in other words, surgery shouldn't be thought of as a luxury. In fact, it should be really written into all aspects of healthcare. He, in fact, said surgical care and social justice in this speech that he gave was the most serious manifestation of social inequity in healthcare. Well, sadly, and probably many of you hadn't even been born in 1980, sadly, even though he made this incredibly landmark speech, not a whole lot of progress was made for many, many decades after that. And then the WHO, more recently, back in the early 2000s, has finally responded to injury, and they started looking into essential trauma care to push for better injury surveillance and research, increase implementation of road traffic safety, and other forms of injury prevention, such as violence prevention, to strengthen our ability to care for the injured. So finally, we're getting a little bit of traction from the impact of the World Health Organization and some other groups. So the guidelines for essential trauma care. So what do you need as a way to start to really be taking care of the population that's vulnerable to injury? And so there are now guidelines for core essential trauma services that every person should expect to receive, even in low-income countries. In other words, it should not be some exclusive luxury item that we just see in high-income countries. The public health and surgery paradigm has finally shifted, and the famous Paul Farmer had coined this phrase back in 2008. Surgery may be thought of as the neglected stepchild of global public health. So wrapping ourselves into your group, people who really do global health, I feel like I finally belong as a surgeon, and that my patients belong, even more importantly. And just as recently as a couple of years ago, the World Health Assembly, this was like a moment to celebrate, passed a resolution to strengthen emergency and essential surgical care and anesthesia as a component of universal health coverage. So this was quite an exciting moment for us. And it meant that we had a seat at the table, and that our patients were going to be able to get the kind of care that patients who have HIV, TB, and malaria are receiving in many of your hospitals. The directive identified and prioritized essential emergency, surgical, and anesthesia care. It was advocacy. It put in place different advocacy components, and it really tried to strive for access, governance, integration of systems, and partnerships. So imagine if one of your HIV patients comes in to a ward and is septic. That particular region where they come into the hospital at first, where you have to do some really massive resuscitation, is an area that can also be used for initial care for the trauma patient. It's also an area that can be used for the initial care of someone who's having a heart attack. So we can share these resources oftentimes, because we all need that essential type of care up front for emergency situations. So it shouldn't be a mutually exclusive, siloed kind of a system. Surgery can be integrated in the foundation that you've already developed in internal medicine and other disciplines. So I'm going to talk just a little bit about the trauma registry in Cameroon, from research to policy, and the impact that it's making. I'm going to go to that in just a moment. So how do we access the data sources for something like road traffic injuries? So why, in other words, is it important for hospitals to keep trauma registries? And we have now registries in 6 hospitals in Cameroon, and we work also in regional referral hospitals in Uganda to help to put these in place. It's all driven by our colleagues in Cameroon. But what we've noticed over time, and we see the same thing here, is that it's really important to understand that police records, newspaper reports, hospital registries, there's a lot of important data, some of which is overlapped, but some is not. So all of these different data sources right now are very important. We did a study with colleagues in India that demonstrated, in fact, for mass casualty events like train crashes, it was very important to look at newspaper logs to understand the overall numbers of the burden of injury. In fact, the newspapers really had a much more accurate report than the hospital registry system. So right now, we really need to take into consideration, if we're really going to understand the overall burden, we need to take into consideration all these different data sources. So several years ago, and now we have this ongoing registry, but several years ago, we started a prospective trauma registry in Cameroon. 2,800 trauma patients were enrolled in 6 months. We found that nearly 50% of ED presentations involved trauma. So that's a significant amount. Emergency department presentations, almost 50% of them were trauma. And the mean age was fairly young. The pattern of injury is very typical in many countries. It affects males more than females, and road traffic injuries made up a significant majority. Major surgery played a role 18% of the time. In other words, 18% of the people who came in needed surgery as a result of their injury, major surgery, and 25% needed minor treatments, probably such as sewing up lacerations. There were a lot of pelvic fractures and extremity fractures, and 30% were head, neck, and face. So what would we do? And I'm jumping ahead for just a moment, but this is a great opportunity for education. So for example, I know I have worked in Uganda for many years, and so many people ride motorcycles and bicycles without helmets. And the reason for this body injury, body area injured, is oftentimes a result of a lack of helmet use. So that's something that's very low cost, but we just need to be able to get the resources there. It's very low cost, and it can save somebody significant disability, because, as you know, traumatic brain injury leads to quite a significant morbidity potentially. And there were people who were quite severely injured. 37% suffered severe injury. Injury severity score is a whole other hour talk I won't get into, but there are issues with some accuracy. But as far as we could demonstrate, many people coming into the emergency department were severely injured. And treatment and cost data, it was very difficult to ferret out, but here's the average cost. So it's important, again, to use this type of information relative to something like a prevention effort, such as handing out motorcycle helmets. The cost effectiveness is very significant. So children are particularly vulnerable, as are males. They're more likely to be seriously injured, and they're more likely to need surgery. This is what the registry actually looked like, some of the information that we were gathering, because we want to understand who's most vulnerable. So we were looking at things like the relationship to the head of the household, education. Why is this important? Because we have to really know who is mostly impacted by injury itself. And other questions to try to get at the economics. So who is coming into the emergency departments? So we used surrogates, such as trying to figure out, so how long does it take you to get to water? This helped us to discern how economically challenged some people were who were coming into the emergency department. And what we found was that here was the distribution of socioeconomic status. So in the Central Hospital of Yaoundé, in other words, the highest quintile of people, or the wealthiest people, tended to come in, and the lowest quintile of people tended to come into DHS. So what it demonstrated to us was much of what they found in a study in Ghana, that many of the people who were coming into the hospital right after their injury were socioeconomically better off. And I'm going to skip this part for the sake of time. And then the poorer patients were more likely to have sought care elsewhere first, as I mentioned. So the lowest quintile sought care elsewhere first. And that meant either a health clinic, a health post, or a district hospital, or just received home care. Why is that important? If that's going to be the case, then we need to compile an understanding of what it would take to treat people at the district hospital, or have a mechanism by which we provided pre-hospital care so that they could get to a particular, a national hospital such as Central Hospital of Yaoundé. And what we found also was that the poor patients were more likely to present with moderate or severe injuries. Not too surprising. So if they did come, it was because they were really profoundly injured. So they were underrepresented, the lower socioeconomic individuals, in hospital-going population. And this is an opportunity for us to really understand what it would take to serve this part of the population in an improved way. It's access to care. It speaks back to that World Health Assembly resolution about everybody needing access to surgical care. And so they typically sought care elsewhere first, and if they were badly injured, they went to the hospital. So we think research, education, health policy, and advocacy, and clinical care actually all affect one another. This particular information was taken to the Ministry of Health in Cameroon, and as a result of that, an injury prevention committee was formed in Cameroon.